Okay, so now we're going to look at some B cell targets. So the first one is CD20. This is rituximab. And so CD20 is a great marker for B cells. And as I said, we don't exactly know what it does, but we know if a cell has it, it's a B cell. And a lot of the B cells that are involved in non-Hodgkin's lymphoma play really an active role in activation, differentiation, growth, and so forth. And so rituximab is a great drug for non-Hodgkin's lymphoma. I think from a step perspective, you should really focus on this one. It's well tolerated, and the success rate for non-Hodgkin's is pretty good. And so I think STEP usually likes to ask about this one in particular. I don't know, for some reason they like non-Hodgkin's lymphoma. It's a monoclonal antibody to CD20, and then it's also conjugated. There's two quote-unquote hot versions, both of which are labeled with a radioactive isotope. They work mechanistically the same way. Okay, and so indication-wise, we're looking at non-Hodgkin's lymphoma, CLL, chronic lymphocytic leukemia, and also rheumatoid arthritis. And so, you may be wondering, these three diseases are completely different. And you're right, but it's the diseases are actually being driven by B cells. Okay, and so the B cell component is our target. And then, as I alluded to in the previous recording, we're also looking at rituximab for solid tumors. Okay, and so you'll probably see there was a clinical trial for lung cancer. I don't remember what the outcome was. This has been another, I don't know, year or two ago. But you can probably expect to see adjuvant status, at least for rituximab, in some of the solid tumors. And so the reason is because a lot of these solid tumors have an autoimmune component to them, typically before tumor initiation has kind of progressed. And some believe that the autoimmune component is actually the initiating factor that promotes some of these tumors. In any case, B cells do play a role in tumorigenesis. We don't know exactly what that role is, but we suspect that they have an important role, and you can probably see something in the next couple of years coming out as to how that works. There are some toxicities. You can get PML, which stands for progressive multifocal leukoencephalopathy. You can get a tumor lysis syndrome as those B cells die. And so you can see like a really almost like a feverish type illness. You can see mucocutaneous reactions. Some of those other conditions are listed there. You don't need to know that, but I just put it out there so that you've seen it. Even bowel obstructions are possible, perforations, reactivation of viruses like the JC virus and so forth. All of those are possible with CD20. And so, just as a reminder, what we're looking at is if we shut down CD20 activity, we're going to be shutting down B cell activity, and we're really going to be looking at altering the humoral component. And so, really, it's these autoreactive antibodies that are coming from the patient that are really driving disease progression in a lot of these different diseases. And so, what we're doing is we're silencing CD20, and we're actually going after some of these B cells and some of these plasma memory cells, so that these cells do not make more autoantibodies or more self-reactive antibodies. And so it's ironic we use a monoclonal antibody to turn that process off, but it's essentially the same thing. So that's pretty much it for the B cell targets. I think the one you should really know about is rituximab. Understand that it has major utility in non-Hodgkin's lymphoma and can have utility in other diseases, and you'll see that coming soon. Okay, so we'll end this right here and we'll go into T cell